I'm sure everybody's awake now. Good afternoon, everyone. We begin scientific session 1, weaving occupation back into life, one stitch at a time. The chairpersons for these presentations are Dr. Meena, Dr. Meena was elected Vice President, All India Occupational Therapy Association from 2020 to 2024. He was the convener of Rajasthan Branch of AIOTA since January 2007. He was nominated for the General Council member of Pandit Deen Dayal Upadhyay National Institute for Persons with Physical Disabilities. He has been on the board of study members in various universities, has more than 30 research paper publications in both national and international journals. He's been a supervisor for over 24 postgraduate students and a co-supervisor for 4 completed PhD candidates. Currently guiding 7 PhD candidates, he has received 18 plus awards, including a Professional Excellence Award by AIOTA. He has attended 19 national conferences of AIOTA, and he's also worked as an organizing secretary for AIOTA conferences and the OTICON 2022. He's been working with Special Olympics Bharat since 2012. After this illustrious person, we meet the next chairperson, Dr. Anna Daniel. Dr. Anna Daniel is the principal of a Bachelor of Occupational Therapy program at National Institute of Physical Medicine and Rehab. She's completed her bachelor's in occupational therapy from Christian Medical College, Vellore, and her master's in advanced OT in pediatrics from KMHC College of Occupational Therapy, Coimbatore. She is certified in handwriting without tears as well as sensory integration therapy. She is also certified in aquatic therapy, in learn, play, thrive approach to autism. She specializes in early intervention, particularly in autism spectrum disorders and neurodevelopmental disorders. And she has extensive experience in specific learning disorders, especially dysgraphia. So we open scientific session 1. Just a few notes for the speakers. You will be given a warning bell at 8 minutes, and then the presentation ends at 10 minutes. There are 2 questions which will be asked for each presenter at the end of all of the presentations. Audiences are please asked not to counter question the presenters. I hope you have an educative session.
Good evening to all delegates. So first scientific session will start. The theme of this scientific session is weaving occupation back into life, one stitch at a time. So judges, please attention, and question answer end of the session already announced. So I request to Anna, please invite to speakers.
The first presenter for today is Dr. Fatima Khatoon. She is presenting a paper on effect of group therapy through relationship-based interactive intervention on each component of social participation in children with autism spectrum disorder. Your time starts now.
A very good afternoon to all present here. My topic for presentation is the effect of group therapy through relationship-based interactive intervention on each component of social participation in children with autism spectrum disorder. Starting with the introduction, social impairment is one of the main diagnostic characteristics for the children with ASD according to American Psychiatric Association 2000. A group is an aggregate of people who share a common purpose that can be achieved through collaboration. Group intervention builds up social relationship. It enhances communication and self-expression, offer multiple opportunities to share learning, enhance social skills, and facilitate client participation. The rationale behind my study is that Tanner in 2015 states that occupational therapy practitioners should consider group-based social skill program to address limitation in social skills for children with ASD. Smith and Arbusman in 2008 states that there are evidences that is relationship-based interactive intervention which focuses on improving the social emotional growth in children with ASD. Therefore, in this study, attempt is made to find out the effect of group therapy through relationship-based interactive intervention on each component of social participation in children with ASD. The aims of my study is to find out the effect of group therapy through relationship-based interactive intervention on each component of social participation in children with autism spectrum disorder. The objectives of my study is to develop the peer interaction, developing social participation skills such as adequately waiting for their turn in a group playing activities, developing self-identification and self-esteem, responding to name call when they are engaged in a group play activities, sharing of toys and sharing of social gestures among peers when they are engaged in group. The alternative hypothesis, there will be a significant effect of group therapy through relationship-based interactive intervention on each component of social participation in children with ASD. Null hypothesis, there will be no effect of group therapy through relationship-based interactive intervention on each component of social participation in children with ASD. The methodology, study design, cross-sectional experimental design. A sample of 40 children with ASD were taken for the study. The study duration from March 2023 to July 2023. The inclusion criteria, children with mild ASD, children without apraxia. The age range was 3 to 5 years. Exclusion criteria, children taking any medication, ADHD children, mentally retarded child, auditory and visual impairment, other associated orthopedic and neurologic conditions. The dependent variables were the components of social participation of children with ASD. Independent variables, group therapy based on RBII. Screening was done by using CARS, planning and idea subscale from SPM home, the social participation subscale from the SPM home. Outcome measure were the social participation subscale from the SPM home. The detailed procedure, 40 subjects were included as per the inclusion criteria. The informed consent were taken from the parents of the subjects. Then they were assessed using CARS, social participation and planning and idea subscale of SPM home. They were divided into two groups, experimental and control, each consisting of 20 participants. The experimental group was further subdivided into 4 groups, each consists of 5 subjects. The experimental group received relationship-based interactive intervention in group, while the control group received individualized relationship-based interactive intervention. 5 sessions a week for 6 weeks for 60 minutes were given to both the groups. Outcome measures variables using social participation subscale of SPM home. Data analysis of each component of social participation were done later. The detailed protocol for the initial 15 minutes package of social interactive strategies were given to the children, like sharing of different gestures like namaskar, hello, hi-fi, shaking hand among each other, among parents and among the therapists, so that they develop the basic social skills. For the next 20 minutes, logotherapy was given. Logotherapy has evidences which shows that if the child is engaged in a group activity, they develop different social skills such as sharing of toys, developing constructional play skills, and waiting for their turn while they are engaged in group activities. For the last 20 minutes, floor time intervention was given, in which the therapist as well as the parents performed in a childlike fashion so that the child basically learns the behavior, how to play in a group activity. The results of my study, after collecting all the data analysis was done by using SPSS version 20. For experimental group, Friedman test was used to find out the changes among each component of social participation score, and Kruskal-Wallis test was used to find out which among the components showed more significant improvement. For control group, paired sample t-test was used to find out changes among each component, and ANOVA test was used to find out which among the components showed more significant improvement. The null hypothesis was tested with level of significance at p less than equal to 0.05. The table 1 shows the descriptive stats of both control and experimental group. Table 2 shows the result of each and between component analysis of experimental group, in which we can see that there are basically 8 components, and while seeing the p-value of the 8 component, we can see that the component A is showing more significant improvement as the p-value is 0.003. The table 3 shows the result of each and between component analysis of the control group. And while comparing among all the 8 components, we can see that the p-value is showing more improvement of the component A. The table 4 represents the component A analysis of the experimental and control group. And by the mean difference, we can see that the component A of the experimental group is showing more improvement. The graph 1 represents the analysis of each component of control group. Graph 2 represents analysis of each component of experimental group. Graph 3 is basically the comparison of the experimental and control group. According to SPM Home, the higher the score is there, the higher the deficit the child is having. On conclusion, however, the subject in the experimental group have shown better improvement in each component of social participation skill as compared to the control group, which is substantially supported by Ellie and Tanner in 2015, who stated that use of group-based social skill training program is in both clinic-based and contextual setting by using techniques such as imitation training, developmental, naturalistic, behavioral, and parent-mediated appear to be effective. Therefore, the experimental hypothesis is accepted and null hypothesis is rejected for our study. Therefore, it can be concluded that group therapy through RBII would be an effective practice rather than individualistic RBII for children with ASD for enhancing each component of social participation skill. Furthermore, in our study, component A, that is the cooperation ability, playing cooperatively with others while they are engaged in group activity, showed more significant improvement than all other components of social participation of SPM Home, which is largely supported by Ranjan and Kajal in 2022, which states that during a group therapy session, children are facilitated to socialize with their group partners while taking turns to participate and wait for a given activity. Group therapy provide opportunity to practice diverse social interaction skills in a safe atmosphere with other children in their age group. The limitation, small sample size which cannot be generalized to larger population, irregularities of the subjects in the group due to some personal reason, the subjective scale used in the present study, although validated, is not completely reliable. The recommendation and future prospect, there should be an increased number of participants in the future studies. Future studies should try to include objective measurement tool for ASD children. The number of participants in each group can be increased or decreased, and its effect can be seen in future studies. These are my references. Thank you.
Thank you, Dr. Fatima.
Thank you, ma'am.
Now I invite Dr. Gina Mary to present the effectiveness of mealtime prep, promoting routines of exploration and play intervention in improving mealtime behavior for children with ASD. Your times. Your time starts now.
My topic is effectiveness of mealtime prep, promoting routines of exploration and play intervention, and improving mealtime behavior in children with autism spectrum disorder. Autism spectrum disorders are neurodevelopmental conditions that affect the areas of social conduct, communication, and stereotypical patterns of behavior. There are numerous difficulties that parents of children with ASDs describe with their children's daily activities. Concerns about meal times are also frequently expressed by the parents. They are particularly due to the rituals and repetition, such as fear of novelty, rigidity, as well as hypersensitivity. To train parents on various intervention components one at a time, behavior activation principles offer a replicable infrastructure. Child behavior modification has been successfully encouraged by parent-led interventions in the past. The PEO model-based interventions may make it easier to have a more varied diet on a regular basis. The mealtime prep interventions, parent-led child-centered component uses social modeling, positive reinforcement, and repeated exposure as its key components. Long-term integration of these techniques into regular family meals is still for maximizing the advantages of ongoing social learning. Need for the study, children with autism, especially young toddlers in India, have a 61% frequency of feeding issue. The best practice recommendation has been to teach parents how to incorporate strategies into a child's natural environment. The aim of the study is to find the effectiveness of mealtime prep intervention in improving mealtime behavior for children with ASD. And the objective is that to assess the eating problems and mealtime behavior for children with ASD and to study the effectiveness of mealtime prep intervention in improving mealtime behavior for children with ASD. Here is a study run by Angela R. Cardwell in 2020, and the purpose of the study was to examine the parent evidence-based strategies using mealtime prep intervention. The data was collected in 3 phases: pre-intervention, intervention, and post-intervention phase. And the primary outcome was measured using BPFAS scale, Behavioral Pediatric Feeding Assessment Scale. And the results indicate that empowering parents is a promising approach to managing child mealtime behavior. And here is another study done by Angela R. Caldwell in 2018. And the study examined the feasibility of using behavioral activation approach to train parents of children with sensory food aversion. And the parents of young children were trained using the novel mealtime prep intervention, and the intervention acceptance was high. Methodology: the study design was quasi-experimental study design. Sample size was 30 children diagnosed with ASD, and the sampling was purposive sampling. Study was conducted in Sri Savavidya Multispeciality Center at Erode, and the duration was 10 weeks. 6 60-minute training sessions for each parent was given before the study. Inclusion criteria: the children diagnosed with autism spectrum disorder by a pediatrician, and the children, those who have mealtime behavior problems, while assessing Bambi scale, brief autism mealtime behavior inventory, and the children between the ages of 3 to 6. Parents of children with ASD, those who can read and write English and Tamil. And we excluded the children, those who are with food allergies, and those who are diagnosed with other comorbid conditions, and those who are following GFCF diet. Procedure: the study was conducted on 30 children, 15 in the control and 15 in the experimental group. Then the children will randomly allocated to both the group, and assessed a training tool was provided. Brief autism mealtime behavior scale and sensory eating problem scale was used to define the presence of eating problems in the children. And as an outcome measure, we used BPFAS scale before and after the intervention, Behavioral Pediatric Feeding Assessment Scale. And the total intervention period was 10 weeks, and we administered the BPAS after the intervention. And we provided 6 60-minute training sessions. And there were 9 strategies in the training session: shared meals with at least 1 adult, family style serving, child participation in mealtime prep, participation and cleanup, reinforcing appropriate behaviors using praise, redirecting inappropriate behavior, avoiding negative language, threats and punishments, demonstrating and encouraging different levels of food exploration, allowing the child to guide their own exploration, incorporating play into their child's mealtime routines. And there were 4 active ingredients of behavioral activation approach to parent training. They are skill training, goal setting, activity scheduling, and activity monitoring. During skill training, we train the parents, and during goal setting, we'll set the goals for next day, and then activity scheduling and monitoring the activity. Data analysis: the data was collected from 15 children with ASD in experimental group who underwent mealtime prep intervention, and 15 children with ASD of the control group not underwent the mealtime prep intervention. The statistics: the scoring was done using BPFAS scale. There was 2 scales in the BPFAS scale. One is total frequency score, and the other one is total problem score. In the total frequency score, we assess the mealtime problems of the children, and in the total problem score, we assess the parental perception about the behavior problem. The t-value was calculated to compare pretest and post-test scores of the control and experimental groups. Independent t-test was done to compare the pretest scores of both the groups and also the post-test scores. Bayer t-test was done to compare the pretest and post-test scores of the same group. Table 1 represents the comparison between the pretest and post of the experimental group. Total frequency scores: the mean values indicate 110.3 and 84 respectively. Table 2 represents the total frequency scores of control group, pretest and post-test comparison. Mean value of pretest is 111.8 and 110.2 in the post-test. Table 3 represents the pretest and post-test of experimental group. Total problem score: it is 18.8 and 11.2 respectively. Table 4 indicates the pretest and post-test of control group, 18.8 and 15.8 respectively in the total problem score. And the table 5 represents control and experimental group comparison in the post-test. The mean value is 110.2 and 84 respectively, and the level of significance is less than 0.000, and it indicates it is significant. Total table 6 indicates the comparison between the control and experimental group of the post-test, and the mean value is 15.8 and 11.2 respectively. Discussion. The primary goal of the research through this study was to determine the impact of mealtime prep intervention on enhancing mealtime behavior for children with autism spectrum disorder. We conducted this study to determine the efficacy of this intervention in controlling mealtime behavior in children with ASD who lack family time and are exposed to gadgets at this time. In order to increase the parents' quality time with their children, proper behavior management and time management skills were given to them during the training period. The same is seen in table 3 and 4, indicating that problems with mealtime that were highlighted by parents have significantly decreased as a result of the intervention. According to the study's findings, training and enabling parents to implement particular evidence-based tactics into their daily routine is a promising strategy for controlling children's behavior during mealtime. Conclusion: to maximize the advantages of early intervention, parent training techniques must be efficient and scalable. Both the child participant and the parent participant experience behavior change as a result of the mealtime prep intervention. And the outcome implies that it is successful in enhancing a child's behavior during meals and easing parental worries. Limitation of the study only lasted a short time and used a small sample size. It was limited to children between the ages of 3 and 6, and data collection restriction was there. Recommendations: future studies could focus on different population and for longer duration. And the studies on specifying family meals are possible. We didn't specify family meals, what the family meals represent in our study. So studies can be done on that particular term, and it can be conducted with people of all ages. Here is my references. Thank you.
Thank you, Dr. Jeena. Now I invite Dr. Kajal Raj Purohit. She'll be presenting on activity limitation and participation restriction among proximal humerus bone tumor patients treated with nail cement spacer. Your time starts now.
Good afternoon, one and all. Today I'll be presenting activity limitation and participation restriction among proximal humerus bone tumor patients treated with nail cement spacer. So I'll let you know about the surgery in further. The proximal humerus is the second most common site of all the bone sarcomas, and for this limb salvage surgeries are preferred over amputation. However, it can compromise shoulder functions, and nail cement spacer is commonly preferred as it is inexpensive, technically simple to perform, and provides adequate shoulder and arm stability, ensuring excellent hand and elbow functions. So although NCS is the preferred reconstructive option, it can cause activity limitation and participation restriction. So various studies have done using musculoskeletal tumor society scores ranging from 63% to 71%. This is the X-ray which I was talking about. So it is the proximal humerus bone tumor. Last image shows the reconstruction using nail cement spacer. This is the anterior and lateral view of the patient following this reconstruction. So we found no study evaluating patients' activity limitation and participation restriction. Hence, this study aimed to evaluate the activity limitation and participation restriction among proximal humerus bone tumor patients treated with nail cement spacer. Primary objective was to measure the occupational performance using Canadian Occupational Performance Measure, to measure performance components using Standard Occupational Therapy Assessment Proforma, emotional outcomes using Depression, Anxiety, and Stress Scale, functional outcomes using Toronto Extremity Salvage Score. Patients treated between January 2010 to February 2021 with curative intent above 18 years of age were included, and local recurrence or metastasis or the current infection were excluded. Screening of the patients was done through medical records, which was procured from bone and soft tissue OPD and also from the appointment list. So we made the telephonic contact to the patients, and the eligible patients were called to the OT department for their follow-up visit on the same day, and one-time assessment was carried out using the following scales. So statistics was used, IBM version 21, and descriptive analysis was used. Demographic details which includes 15 patients with mean age of 29.67 years, and the follow-up period was 69.6 months. 80% were males, 20% were females. Diagnoses were chondrosarcoma, Ewing sarcoma, giant cell tumor, osteogenic sarcoma, and primitive neuroectodermal tumor. 53% had affectations on the right side and 47 on the left side. Along with nail cement spacer, the intercalary resection and Tikoff-Lindbergh were included. Table 2 shows active shoulder range of motion of all patients. Shoulder horizontal abduction and adduction was absent, and internal rotation was least affected, whereas flexion, extension, external rotation were majorly affected. Muscle strength had a range from poor muscle strength for the shoulder group of muscles and elbows fair to good. Deep sensations were intact in all the patients, and superficial touch sensation was affected for 47% of the patients. And out of those, majorly affected location was lateral aspect of arm, forearm, and anterior aspect of above elbow. Distribution of scale. So 20% patient had reported stress, 40% anxiety, and 33% depression. Graph 7 shows Canadian occupational performance measure, in which performance score was 5.26 and satisfaction was 3.8. So difficulties reported majorly were bathing, washing hair, combing hair, dressing upper extremity, wearing socks and shoes, eating, brushing, buttoning, in transportation in crowded places, traveling in public transport, and productivity included all the difficulties in occupation, such as while taking things from the upper shelf of the shoulder and above shoulder level activities, housewife, managing household chores, finding a job. Difficulties reported in quiet recreation, mehndi drawing, computer gaming, playing badminton, cricket, etc. And in socialization, phone calls, and visiting friends and neighbors. The mean test score, the functional outcome was 54.17%, and 40% scored in the moderate range, whereas 60% scored in the good range. A quick review. So why I chose this surgery? Because it is the cheapest and most widely used, and many articles assess the functional outcomes, but none assessed patients' participation in routine life tasks. We did this post 69.6 months of surgery. 15 patients were included, and 9 out of 15 patients had the tumor in the dominant hand. So we came across 2 studies by Rugri and Valid, which reported a similar mean active shoulder ranges. And we did not find any study which assessed the other shoulder ranges, although these ranges are important for carrying out many routine life tasks at home, at work. We found that one of our study patients had a near normal functional shoulder extension range, and 8 patients had complete active shoulder internal rotation. Authors who studied functional outcomes, they did mention the good functions at elbow and hand, but they did not assess the shoulder strength in their patients. And we assessed that. Sensory assessments were, we did not come across any study that sensory assessments were performed. Emotional outcomes, so many studies have done that using musculoskeletal tumor society score, but it comprises emotional status as one of its 5 components. We evaluated using the DAS-21 emotional health as an independent measure. So another study by Lindsay Sposato reported poor psychosocial outcomes in traumatic injury patients who underwent upper extremity limb salvage surgery using reactions to impairment and disability inventory. So this study suggested possibility of poor outcomes because of patients' inability to participate in routine task roles and activities, and not having enough supportive social network. Functional outcomes in our study was found to be lower than the reported MSTS scores. It was found to be ranging from 63 to 71%. Not this.
We'll pause the timer.
Okay.
Yes.
Okay, so it is the first observational study to highlight the rehabilitation needs. It provided the insights, and it is recommended that we have to understand the phases of rehabilitation without underestimating their late phases. So thank you, and I would acknowledge my institute and guide for guiding me. Thank you.
Thank you, Dr. Kajal. Now I invite Dr. V. Soundarya to present exploring the integration of sexual health and sexuality in occupational therapy practice within the Indian context. Your time starts now.
I'll be presenting my research on exploring the integration of sexual health and sexuality in OT practice within Indian context. In OTPF4, sexual activity is described as engaging in the broad possibilities of sexual expression and experiences with self or others. Though healthcare professionals across the globe recognize the importance of addressing sexuality and sexual health, it is also seen that they fail to do so in assessment due to a lack of knowledge and comfort. However, there's a stark gap in literature that is seen regarding this issue in the Indian context. So we tend to identify.
Please pause, Dr. Soundarya. Please pause. We'll start this session again from the beginning. Your time starts now. The mic is not working. Your time starts now.
So after a few technical difficulties, this is Dr. V. Soundarya, and I want to talk about how I explore the integration of sexual health and sexuality in OT practice within the Indian context through my study. Introduction. Under OTPF 4, sexual activity is described as engaging in the broad possibilities for sexual expression and experiences with self or others. And though healthcare professionals across the globe recognize the importance of addressing sexuality and sexual health, it is also seen that they fail to do so in assessment due to a lack of knowledge and comfort. However, there's a stark gap in the literature that is seen regarding this issue in the Indian context. Though we tend to identify a few norms concerning sexuality, the influence of the Indian context on it and the relevance of this on OT practice largely remains unexplored. Even when we find resources and relevance, they tend to originate from foreign sources. We recognize that the talk regarding OT addressing sexuality in India may not be absent, but it is not reflected in the literature. My objectives were to explore the integration of sexual health and sexuality in OT practice within the Indian context by understanding the knowledge, practice, belief, and comfort of Indian OTs in addressing sexuality and sexual health with Indian clients, and understanding the views of OTs on addressing sexuality and sexual health in India. My methodology was to do a pan-India cross-sectional online survey. We selected the Heck and Young questionnaire by Young et al. In 2020, and it had 5 components: the demographic data, the practice belief of 8 questions to be rated from disagree to agree, knowledge in 24 related topics from none to excellent, comfort in 14 statements rated from uncomfortable to comfortable, and general questions which can be treated as a yes or no question or as an open-ended question. After selecting the questionnaire, we obtained the permission and questionnaire from the author of Young et al. 2020 and converted it into a Google form. And we also distributed our questionnaire through WhatsApp, LinkedIn, email, Instagram. We got a total of 152 responses, out of 4 were excluded. We ended up with 148 responses on which we did descriptive and thematic analysis. My results and discussion in demographic, we see that the number of male respondents were almost double the number of, the number of female respondents were almost the double of male respondents. And there were a lot more single people in my study. We also saw that the majority of my population had up to 5 years of experience, and most respondents were in a clinical job description. Practice belief. In agreement with existing research in other countries, our results show that while most OTs believe sexuality is an important component of holistic care, more often it is not addressed in clinical practice. This gap can essentially be a result of societal discussions surrounding sexuality and disability, along with the professional conversation that prioritizes specific occupation over alternative ones. However, our results show that Indian OTs had divided opinion on discussing sexuality in acute care, while other countries see sexuality to be important on all levels of care. We also saw that in knowledge, very few OTs seem to have reported excellent knowledge about any of the topics. There was better knowledge on safe sex practices and STDs, followed by sexual anatomy and physiology. No one had reported to have excellent knowledge about the use of medication for sexual dysfunction. And most people had poor knowledge of methods and techniques of sexual therapy and counseling. OTs in administrative roles unanimously reported excellent knowledge on a few topics, namely sexual abuse, sexual diversity, and the OTs in teaching roles have not reported excellent knowledge on any topic. Similarly, people with more experience and age have often not reported excellent knowledge as compared to others. It was also seen that no male respondent had reported excellent knowledge on female sexual dysfunction. The majority of married OTs had reported limited knowledge, and no one had excellent knowledge of male sexual dysfunction. In comfort level, our respondents were more comfortable with working with a person who identifies in the LGBTQIA+ community, answering client questions on matters relating to sexuality, working with a person in a wheelchair who is inquiring about sexual options, and working with a minor seeking contraceptions. They reported to be more uncomfortable on conducting an assessment that involves exposure of the client's breasts, buttocks, or genitals. It was observed that Indian OTs have higher comfort and knowledge when talking about more controversial yet popular topics in the media, like the LGBTQIA plus community and STDs in general. This could be because of the increased awareness that has been created by social media, or maybe the clients might have been desensitized to do these topics, again because of social media. Although few studies explore this, and fresh graduates often feel they have no knowledge and preparedness for treating LGBTQIA plus clients. Further research is necessary to explain this phenomenon. OTs in teaching roles, OTs with more than 5 years of experience, and OTs who are about 30 years of age are more comfortable with addressing most sexuality and sexual health related issues. A few respondents commented that their religions and cultural norms have made them uncomfortable discussing sexuality. We also noted in our qualitative analysis that few respondents would initiate the conversation if the client was comfortable with it, or if the client is asking about sexual issues. This could have been tended to with the knowledge of the explicit model, where taking permission is the first step. A similar issue was also reported in Young et al. In 2020. In barriers to addressing client sexual issues in OT practice, we saw that lack of knowledge rated the highest, followed by lack of comfort and privacy. The client's religious and cultural beliefs also posed a significant barrier to our OTs. Though 95% of OTs believe that addressing client sexual issues is a legitimate domain of practice, only 24% of respondents are currently providing sexual education or counseling to their clients, and only 11% of OTs have received any additional formal training or education regarding addressing sexuality. The majority, that is 70%, see a connection between their knowledge and confidence, but only 22% have received education or training in their OT curriculum. Overall, only 22% of OTs who responded to this study feel adequately prepared to address client sexual issues. My qualitative findings were that sexuality is rarely addressed in therapy. There is a need to balance this issue with cultural context, and OTs working with pediatric or psychiatric population reported to frequently address related topics. This could be because most communication is via a caregiver, or that it might be deemed necessary as assessment includes psychosexual factors, sexual history, sexual development, and sexual safety. Most do not feel confident talking about sexuality because of a lack of knowledge, and do not feel comfortable because of a lack of private space. Although topics like sexual response cycle were part of some curriculums, people responded that they were not confident about the knowledge they gained. Even though 88% of respondents have not received additional formal training, some have had discussions with their team or taken initiative to read up on their own. When asked what would help our OTs feel more comfortable, confident, and competent in addressing client sexual issues, we received answers as special training, conference, seminars, lectures in the OT curriculum, real-life clinical practice, discussion in practice, reducing stigma around sexuality, improving the comfort of clients who are such discussions, and a distraction-free environment. Studies have also shown similar results as this study that OTs' lack of knowledge affects competence and how they address sexuality. It has had a great effect on the comfort of OTs around this topic. Future research, we would like to explore the implications of this study on OT education, bridging knowledge gaps, and assess the barriers and address them, the importance of context and sexuality for holistic care. In my limitations, we had 3 major limitations. First was a lack of knowledge, which might not have led other issues and suggestions that our respondent might have had to get enough attention for them to report it in the survey. And that it was a subjective survey. They might have scored themselves low on the scale, and that might not be indicative of their competency. We also saw that there were only a total of 2 people in purely administrative capacity. Conclusion, sexuality and sexual health is an important component of well-being and holistic care in OT. Despite this being the case, OTs in India generally do not address it in common practice. Almost all OTs acknowledge the importance of sexuality, but because of the lack of knowledge, private space, and cultural religious factors, they tend to not do so. They urge sexuality and sexual health be included in OT curriculum in India and provide other formal education regarding this to better their knowledge and ultimately OT services. Through this survey, we hope to put our first step forward in exploring sexuality in OT practice in India. Our study represents a pioneering effort in this category, and future research is needed in our context. We also hope that by participating in this survey, we have opened up a platform for further discussions on this topic in OT practice, education, and services. Further exploration and action towards OT education and services in this area is needed. These are my references. Thank you. I would also like to acknowledge every OT who's sitting here who responded to this survey, and Dr. Kelly Young of University of Toronto. Thank you.
Thank you, Dr. Sandhya. Now I invite Dr. Ananya Jana to present on the effect of activity-based sensory re-education training on symptom severity in patients with carpal tunnel syndrome. a comparative study. Your time starts now.
Good afternoon to one and all present over here. My topic is the effect of activity-based sensory education training on symptom severity in patients with carpal tunnel syndrome, a comparative study. Carpal tunnel syndrome is a common type of entrapment neuropathy of the upper extremity, which is caused by the compression of the median nerve at the wrist level, causing somatosensory deficit in the thumb, index, middle, and lateral half of the ring finger, and in severe cases, causing motor deficit in the thumb. Somatosensory system plays an important role in sensory motor integration, and motor functions of the hand can be affected by the loss of sensation. It has also been observed that motor functions are enhanced by the improvement by its sensation. Thus, it can be hypothetically assumed that hand sensation can be correlated with the symptom severity. Sensory education is a technique used in somatosensory rehabilitation, and activity-based sensory education uses simulated real-life activities instead of passive tactile stimuli. Attention, active participation, and use of visual feedback are the main component essential to facilitate somatosensory sensation of hand. Therefore, based on the current knowledge and development in the neurophysiologic and cognitive science, an active cognitive approach has been utilized, and the present study was proposed. The aim of the study is to study the effect of activity-based sensory education on symptom severity in the patient with carpal tunnel syndrome, with the objective to determine the effect on hand sensibility and to determine the effect on symptom severity. Study design is a pre-test, post-test experimental study design with a convenient sampling with random allocation was used. Sample size was 30 with a study duration of 8 months, and intervention period was 4 weeks, 5 sessions per week for 1 hour a day. Inclusion criteria are age range from 20 to 60 years, both males and female diagnosed as CTS. Hand sensation should be affected with the presence of protective sensation. Exclusion criteria are any psychiatric illness, severe cognitive problem, any other comorbid neurological diseases, history of wrist surgery or fracture or carpal tunnel injection 2 weeks prior to the study. Outcome measures used are short version of Sims-Svensson monofilament for checking sensory threshold and symptom severity scale of Boston Carpal Tunnel Questionnaire for checking symptom severity. Procedure: an informed consent was signed from the patient and patient was screened out according to the inclusion and exclusion criteria. Using the outcome measure, a pre-test baseline data and a post-test data after the 4 week of treatment was taken, and the patient was allocated into 2 groups, in which the group 1 was experimental group, where the patient got treated for 4 weeks of sensory education protocol for 20 minutes per session, and again repeated the same at the home for the 20 minutes. The patient also received traditional therapeutic exercises, which include tendon gliding exercise, median nerve gliding exercise, and proximal conditioning exercises for 20 minutes session a day. Group 2, which was control group, where the patient received only traditional therapeutic exercises for an hour per session, where 30 minutes they practice in the department and other 30 minutes they are asked to do same in the home. Sensory education, which was activity-based task, include 9 steps, in which the first step was multi-sensory stimulation, where the patient shall be on the headset with a soft musical beat, mirror for the visual illusions, and room freshener for the olfactory stimulation, where larger part of the brain shall be activated. Figure 1 shows some of the ideal tools and familiar objects where patient was asked to manipulate and functionally use the ideal tools. Figure 2 shows some of the vegetable and fruits commonly available for the tactile meal. Figure 3 showing texture sorting with discrimination, density discrimination, and for density we use water, sand particle, and rice particle. Figure 4 shows manipulation of Rubik cube and Ludo dice using 3 fingers of thumb, index and middle finger. Figure 5 showing texture manipulation with mirror illusion, and figure 6 showing some of the common bilateral hand activities. Data analysis was done with IBM SPSL software version 29.0 with the label of significance set at p less than equal to 0.05. Non-parametric test was used for both the outcome measure, where the Wilcoxon sign rank test was used to analyze within group differences, and Mann-Whitney U test was used to analyze between the group differences. Mean change of score, standard deviation, and probability value was calculated within and between the groups. Results show table 1 shows the demographic data of the patient, where the number of subjects for the experimental group for both pre-test and post-test were 15, but in control group, after taking few therapies, 2 patients dropped out. So for post-test data, only 13 patients were there. Mean age for experimental group was 42.53 with a standard deviation of 8.93 for the experimental group, and for the control group, it was 46.0 with a standard deviation of plus minus 8.61. Table 2 shows the result of symptom severity within group analysis of the experimental and control group, showing significant result and decrease in the mean score post-treatment. Table 3 shows between group analysis of experiment and control group, showing significant result with a higher mean difference score in experimental group when compared with the control group. Table 4 shows within group analysis of the components of Simpson monofilament of experiment group, showing highly significant result with an increase in mean score of all the components post-treatment. Similarly, table 5 shows within group analysis of the control group, revealing an insignificant p-value with decrease in mean score post-treatment in area number 11. Table 6 shows between group analysis of all components of Simpson monofilament, showing significant result, but the mean difference score of the control group in area 11 gives a negative result. However, the overall results show a significant improvement in all components of Simpson monofilament in experiment group when compared with the control group. The sensory education training protocol used in the study applied active cognitive approach, which means activation of sensory neural pathway depending mainly on participants' ability to learn using their cognitive and perceptual skill. The finding that the sensory threshold of the affected hand significantly improved post-treatment in the experimental group agrees with Gerard et al. 2011, reporting that the somatosensory rehabilitation requires brief and frequent practices in the tactile discriminative task. These findings are further supported by the literature according to Lawson and Lundberg, as they mention that active and conscious use of the hand in daily activities as well as attention during training combined with high motivation by the patient is extremely important. It was further noted that there was decrease in sensation in texting area 11 in the control group. Upon further investigation, it was found that the patient who reported the same uses paniki, an Indian cutting tool, which might attributed to repetitive unwanted tasks causing unfavorable changes in the associated areas of the sensory cortex, as reported by Terry and Osterman in 2011. Improvement in the symptom severity score that was found in between the groups after treatment might be attributed to the effect of the therapeutic exercise program, agrees with Warren et al. 2011, reporting that standard physical therapy intervention is effective in treatment with CTS symptom. Our findings also reveal that symptom severity score shows a better improvement in experimental group, goes in support of the study by Fatima and Yusuf et al. 2020, reporting that traditional therapeutic exercise in addition to the sensory education paradigm to be helpful in improving sensation, symptom severity, grip strength, functional status of the affected hand in the patient with CTS. In the view of the findings of this study, it could be concluded that activity-based sensory education training along with traditional therapeutic exercises have a positive effect in improving the sensory function and improvement in the symptom severity of the affected hand of the patient with CTS. Therefore, it could be recommended to consider this useful and affordable therapeutic regimen in the rehabilitation program in CTS patient. Limitation were small sample size, differences in the recovery processes in female and males and different age group are not analyzed, and the lasting effect of the sensory gains could not be analyzed because of shorter duration of the study. These are my references. Thank you.
Yes, thank you. And now open for question answer. So I request to all presenters, please come on the stage. Only 2 questions, no cross questions.
Please come onto the stage. Dr. Fatima, Dr. Jeena, Dr. Kajal, Dr. Soundarya, and Dr. Anand.
Hi, I'm Dr. Soumyakan Sahu. So my question is to Dr. Fatima, rather the query. You use 2 different set of tests into different your experimental and control group. So how did you conclude that which test has to be done, whether it is a parametric distribution or non-parametric distribution?
Hello. Hello. Sir, I would kindly like to answer your question. The control group received individualized relationship-based interactive intervention, and the experimental group received that intervention in a group. So it's the individualized relationship-based interactive intervention is basically the conventional therapy which helps to develop the social emotional goals for children with ASD. And in RBII was given in a group for a group therapy for experimental group. So
Pardon, my question was related to the study test.
He asked why you use different statistical analysis for experimental and control group.
okay. For experimental group, as there were 4 subgroups within my experimental group, so for that reason, I have used Friedman test for getting the each component analysis, and which among those components showed more significant improvement. For that, I have used Kruskal-Wallis test, as because there were subgroups in the experimental group. That's the reason.
What?
I'm Dr. Deepa Sundareswaran. I would just wanted to know what exactly was the difference in the therapy that was provided. It was group or individual. Apart from that, in your relationship,
Based interactive intervention.
exactly, yeah.
The same intervention was given both the group, but in experimental group, it was given in a group of 5 subjects in one group, and individualized RBII was given for the control group for 20 participants.
Just small suggestion. It would be nice if we could use the word intellectual disabilities, because I use the term mental retardation over there. As per RPWD Act 2016, we're not supposed to use that.
Oh, okay, ma'am. Thank you.
We'll take 2 questions for Dr. Jeena.
No questions for Dr. Jeena? If Meena sir or Anna ma'am have any questions for them.
Dr. Jeena, why did you choose the age criteria, inclusion criteria as 3 to 6?
Because there was an article related to that. They said that the prevalence of mealtime problem behaviors are shown in that particular age because they are introduced to the new food at that age. So, and there were articles regarding that, ma'am. So I thought.
And when you say mealtime behavioral issues, does it what all comes under the mealtime behavioral issues?
Tantrums mainly due to the sensory food aversions, the sensory food preference, picky eating. These are all the main mealtime behavioral problems, preferences towards textures, new food items, rejecting new food items, and throwing tantrums during the mealtime, then avoiding particular food items. These are the mealtime behavioral problems.
But We can see that in older children with ASD also, right?
It was more in that particular age as they were introduced. They are
So did you,
newly introducing at that age.
no, did you do any study, like a comparative study, like to find
No,
out
no,
whether,
there was-
no, you
No, no,
have.
no. There was studies regarding that.
Okay, your literature. Thank you. Yes, question for Dr. Gina? Yes.
Hello, doctor.
Yes,
So
ma'am.
I wanted to know about the play techniques that you mentioned for mealtime behaviors and were they a cause of distraction in your study?
Yes, we use exploration and play during the mealtime. The play means we are not forcing the child, we are not threatening, and we are not punishing the child during the mealtime. We provide play in the sense we are letting them to explore the sensory exploration, like the smell, the color. We'll just introduce and say, see, the beans is green. See, smell is like this, like that. We are just, if they want to explore with the hand, we are letting them do that. So these are the exploration and play coming under this. And there will be a plate. One is targeted food and the preferred food. So we are administering the preferred food and the targeted food will be in a plate. And the targeted food we are not forcing. We'll just give it for exploration and play. Thank you.
Thank you. Now we'll move on to questions for Dr. Kajal.
Hello, everyone. As you have mentioned, the
Please
surgery.
introduce yourself first.
Hello, everyone. I am Rosalind Pratihari. I have the question that you have mentioned most of the female are seen in that undergo surgery. So, are they cosmetically accepted? What is the review that you have gained from the females as that you have shown a picture of that surgery? It is cosmetically looking not good. So, what is the response from the female about the surgery?
Thank you, ma'am, for the question. So, cosmetically, yeah, it doesn't look that good, but it is better than other reconstructive surgeries as the shoulder is well intact and it provides adequate stability at the shoulder joint. So, cosmetically, we actually did not evaluate like what are the outcomes. So, I think I would like to do that if I got any chance.
Any other questions for Dr. Soundarya? Yes.
Hello, I'm Dr. Somyakan. My question is to Dr. Kajal. So after your research is over, did you think of calling back those participants to improve their and try to engage them in your OT practice to improve their functionality or whatever the challenges you found out in your study? Or did they follow for the sessions, or it was just meant for the study?
So it was actually just meant for the study. So there isn't been any study that has evaluated the rehabilitation needs. So first, that's why I chose a long-term follow-up period surgery, because at after the particular point, after 2 years, how much ever their function they have achieved, we cannot reverse that. Like that is it. But what we can do is I have also given them at the same time that what are the compensatory strategies that they can use to do their activities of daily living. So that I had done to the patient, that how much ever functionality can be achieved, that they can do. But most of the patients, what happened was 5 years 6 years post surgery, they had actually changed their dominance to do all the activities. So they had actually well accepted the surgery and their particular situation. Thank you.
Thank you, Dr. Kajal. Now we'll take questions for Dr. Soundarya.
Dr. Soundarya, I think more than a question, I think huge round of applause for taking such a wonderful topic. And it is something topic which everybody would hesitate as a therapist and who've been experienced also. And kudos to you. And really just wanted to know what made you take that topic. Really, it's. And even while listening, many would have been comfortable too, actually. I could see some faces going, that was really, so I just wanted to know that.
Thank you so much, ma'am. Honestly, it was my own experiences.
Absolutely.
I am pretty young. I haven't had enough experience. But when I meet clients who express either a need for sexual intervention or sexual suggestions that are not appropriate in therapy, I had almost none to limited knowledge on how to respond in that situation. We are taught OTPF, and under OTPF, it is a domain under ADL. But not being able to address it was very uncomfortable for me. So I wanted to start somewhere. So I thought we can start by knowing if everyone has the same feelings as me.
Okay, great. That's really great. Fantastic.
Thank you, ma'am.
Actually, what I do know,
Yeah.
whenever there's a male patient, I ask male patient. Whenever there is a female patient, then also I ask. So then only everything will be clear. Okay.
Sorry, sir, I'm not able to hear you.
See, whenever patient is himself a male patient, we can ask him because you are a lady, probably you must be thinking it is better for you to communicate only with his wife. So you can communicate with his wife. Whereas if I am a male and male patient is there, I have to communicate with him. And if the patient is female, then also I have to communicate with him, her husband. So it should be like, so then everything will be clear.
Sir, I'll follow that from now on.
Yes, one other question.
I totally agree with Dr. Deepa ma'am regarding this. I have rather a curiosity. So after your study, what changes you made in your OT practice and what changes you saw in your fellow OT colleagues as well?
So the first thing was the discussion on this topic started, at least in my friend circle. It might not be always OT related discussions, but discussions about the history of India on this topic has started. The other thing is, I came to know the explicit model only through after reading up on this topic and doing this survey. So now, at least, I tentatively ask my clients if there are sexual issues they would like to discuss. If they say no, we stop there. If they do have issues, I take it to my professors and someone who can guide me on this, on how to proceed. At least I'm trying, and I know my friend circle, people closer to me are discussing this topic. Apart from that, I guess time will tell, sir.
Thank you. Thank you, Dr. Soundarya.
Thank you, everyone.
Now we'll take questions for Dr. Ananya.
Hello, I am Nisarani Pradhan. What is the importance of giving proximal conditioning exercise for CTS patients? Okay, in CTS, the median nerve is been distally irritated, for which the exoplasmic flow is getting hampered, which could further lead to proximal irritation because of that anoxemic plasmic alteration. For that, we are giving proximal conditioning exercises for making so that the patient will be having a good posture with some of the conditioning of the shoulder muscles to proceed with further tendon gliding and median gliding exercises. Okay, thank you.
Hello, I am Ms. Sanjeevani Patel.
So, ma'am, my question to you is, what is the correlation of using the Indian cutting tool which decreases the sensation in area 11?
Okay, so basically the area 11 suggesting the pad of the thumb. The Indian cutting tool, which was a spatial observation we have observed, that is a paniki, which means a wooden base with a iron, for which while cutting, the patient puts much more pressure over the thumb area. That is area number 11, according to Sims-Winston monofilament. For that, and the pad of the thumb is also basically used for the opposition purposes also. So because of which there is repetitive unwanted task, and which could lead to the negative sensory cortex, negative association and changes in the sensory cortex, as it was reported by Terry and Osterman.
Thank you, ma'am.
Okay, so now session is over. Thank you all presenters. Session was very good and interactive. All contents, your research study was very well. All presenters are finished within time period. So thank you very much to all.
Thank you, sir.
Presenters, please wait. Take your certificates and then you can leave. If we could please have the chairpersons distribute the certificates. Dr. Fatima Khatun. Dr. Jeena Mary. Dr. Kajal Rajpurohit. Dr. V. Saundarya. And Dr. Ananya Jana. Thank you for such a wonderful, educative, scientific session 1. Now we would like to call Dr. Arun Kumar sir to felicitate Dr. Meena and Ms. Shanta Pandian ma'am to felicitate Anna ma'am.